Hey, good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. We've got a jam-packed program for you today. Doc Hawk is here to provide a COVID update, including some new science telling us more about long COVID, and I have a quiz for Hawkeye. He doesn't know that yet. It's going to be fun. We'll also talk about exercise and its link to cancer care with the physician-in-chief at our cancer center. But I am so very excited to talk this morning about this next topic. It's approximately a very big deal in the world of medical research. Healthcare is based on science. You've heard that on this program many times, and that science depends on research. And research ideally account for each person's differences in biology, behavior, and environment. The University of Kansas Medical Center is helping make sure folks here in the Midwest are represented in an important nationwide research program called All of Us. Helping to explain, we have Dr. Akinlolu Ojo, the Executive Dean of the KU School of Medicine. I'll call him Dr. Ojo. And Tammy Peterman, President of the Kansas City Division of the University of Kansas Health System. So what is the goal of the All of Us research program?
The goal of the All of Us research program is to help bring to reality precision medicine for all our citizens. And in this effort, we are working to make sure that residents in this part of the Midwest are able to participate in the All of Us research program. What it ultimately means is that individuals will be able to receive care that is tailored to their specific biologic factors, including genetic factors, behavioral factors, environmental factors, and other individualized attributes that makes for a precise tailoring of treatment and prevention of disease.
Boy, that sounds just amazing. Why would someone want to sign up for this in your sense? Tammy Peterman.
You know, Dr. Stites, I think it's because you can learn a whole lot more about yourself and about your health. And certainly you'll learn about DNA and genetic traits, but it also will give us an opportunity for people to learn about potential traits or conditions in the future. I think that's really important. And because this is a really broad and diverse database, I think we can learn more about communities and certainly future generations as well. So I think there are so many reasons that people will want to participate. It also will give us some indications as to how individuals will respond to certain medications, and then hopefully in the future it will help us develop better treatments and medications for treating.
It sounds like really the whole frontier of science, and hopefully people are going to want to be part of that. If people do sign up, Dr. Ojo, what's expected of them?
What is expected of those who sign up include a donation of blood and urine specimen. Some of those blood and urine specimen will be used to extract genetic materials, so that DNA can be used for genome sequencing. So that's part of the expectation. Individuals will answer survey questions. They will also have limited physical measurement, and they will be expected to fill out questionnaire on their behavior, their environment over time. We will also want the opportunity to contact individuals who sign up on a periodic basis to provide additional information about their health. We will also ask them to donate their health record, if they have any, into this research resource that can be analyzed along with other materials that they donate. And individuals will also have the opportunity to receive results from testing that are done on their material where that is relevant, if they choose to.
That sounds like a big commitment, but a great thing to do to help advance the science. So if people want to sign up, Tammy, where would they do that?
Well, they can do it. It's pretty easy. You can go directly to joinallofus.org, or certainly by speaking to your healthcare provider and participating organizations like ours.
That is a darn big deal. Well, thank you very much for coming down. I know we're so darn excited. Tammy, Dr. Ojo, thank you both for being here. Any last minute things you want to tell us about it?
No, I think this is pretty exciting.
I'm really excited.
We want everybody to sign up.
Yes, we do. That's awesome. You know, when patients have the opportunity to participate in science. It's so remarkable that they're making that donation of their time and contributing themselves into that, because that's how we advance medicine and find new cures to disease.
Yes.
All right, thank you both very much.
Thanks.
All right. So exercise is one of the best things, if not the best thing, you can do for your health. Exercise is medicine, but instead of just hearing it from doctors like me, we sent a camera so you can see it too. Here's Alexis Del Cid.
Just getting warmed up.
Whether it's the gym, the pavement, or the pool, ask these University of Kansas Health System healthcare workers what motivates them. You'll get similar answers.
There's now evidence that strength training makes a difference in your survival.
I'm definitely a firm believer that exercise is medicine.
It's just as important as the medications that you're taking because it'll really give you those long-term effects.
It's really an easy, non-pharmacological way, non-surgical way to help treat some of our ailments that affect our cardiovascular conditions. I'm gonna try to push it.
RN Elizabeth Hart is a competitive bodybuilder.
2017 is when I did my first one, and I did it kind of as like a bucket list thing.
She's been hooked ever since.
Okay, I can do my heavier weight. Kind of smile so he doesn't know I'm hurting.
Cardio-oncologist Dr. Charlie Porter,
Stop and switch.
a regular at the Westwood Cross Training Club.
So this is just a stomach-wrecking ab exercise, but they call it driving Miss Daisies. That's like we're driving the car.
You gotta work when you come in here. There's no dilly-dallying around.
Family and sports medicine physician Dr. Nicole Yedlinski is a marathon runner, currently training for a triathlon.
Oh my goodness, it's probably one of the most meditative exercises that I feel humans can do.
And advanced heart failure and transplant cardiologist Dr. Paula Roldan
Been doing this since college.
is up at 4:30 every morning.
I like working out in my home gym because it's convenient, it's accessible. I have accountability with my husband.
When it comes to talking with their patients about the importance of exercise, all four say their core belief that exercise is medicine makes it a no-brainer.
I love talking about nutrition and exercise with anyone. It's my second passion next to nursing.
If you walk 2 or 3 hours a week, after you're about 40, you start to reduce your risk of cardiac death.
It's been studied in a lot of cardiovascular patients, diabetic patients, obese patients.
I think it gives me some credibility, especially with the adolescent crowd, that they see me out here doing these things.
Boom, boom, boom. There you go.
All right, joining me now is Dr. Jeff Holzberlein, a urologic oncologist, that's a mouthful, at the physician-in-chief at the University of Kansas Cancer Center, a good friend of mine. I want to hear about his attempts at body sculpting in a moment. But before we talk about exercise as it relates to cancer, we do have some extra footage, Jeffrey, of one of your own workouts. And just to say, this is body sculpting in action.
Pick your favorite. They're ready to go from the bullpen in right field.
That's you. You're the catch-up.
That would be me. Jeff Wright is mustard. And Dr. Mark Hoffman is relish.
Final wagers, please.
All right, here we go, baby. This is going to be too much fun. So Relish got way out ahead in front of you guys.
He did. He had a great start to his race. Then he got a little confused, started running backwards.
Yeah. Is that effective having to work with you, or what is that?
That could be. And then I had a little burst of speed there, but maybe need to spend a little bit more time with endurance there.
I think
kind of faded at the end.
I think the three of you look like you tried to fix this so you guys could all finish together at the same time, so it looks like to me.
Everybody enjoys a close race.
Yeah, except Mustard. You know, typically for Jeff Wright, he just had to get a little ahead at the end.
That's right. That's right.
Oh, that was pretty awesome. Well, that was a really big workout right now. Maybe we should get back to the science about this. That was an interesting study published in the Journal of Clinical Oncology in 2020. It pulled data from 9 large cohorts, that means different groups, looking at more than 755,000 adults over 10 years. People who regularly exercised had significantly reduced risk of developing 7 different types of cancer. Talk to us about that.
Yeah, so, I think there's been a lot of evidence over the years that has been somewhat difficult to interpret regarding the value of exercise as it relates to cancer. I think it's unequivocal that exercise benefits us, particularly in our cardiovascular health. But its link and its relationship to cancer has been a little bit more confusing. I think this study was, as you mentioned, an observational study, so we have to be a little bit cautious about the conclusions that we draw. But the advantage of this is there's almost 800,000 people that participated in this study.
That's a lot.
And it did demonstrate significant benefits in cancer rates, the detection of cancer for those people had a lower risk who exercised. So pretty important and pretty powerful data.
So colon, breast, endometrial, kidney, liver, myeloma, and non-Hodgkin's lymphoma kind of were singled out. Do you think that was due to the actual exercise or maybe an absence of obesity? Or did we pre-select that these people just have healthier lifestyles because they exercise?
Well, I think those are great questions, and I don't think we truly know the answer to that. But they did attempt to control for obesity in this study. And really the only a cancer that didn't seem to maybe benefit quite as much was endometrial. All the others, even when they controlled for BMI or body mass index or obesity, did show that exercise continued to lower their risk of cancer. So I think there's something really there about exercise lowering the risk of cancer.
So that's a big darn deal. Now, you and your team and the team around you handle a lot of prostate cancer cases. You were involved in looking at some research about weight management as it relates to prostate surgery outcomes. Tell us a little bit about this Warrior study. I love that Warrior, by the way. That's pretty cool.
So actually Warrior was weight loss aimed at reducing risk associated with prostate cancer. And it really was a sort of targeted intervention where we were looking at both exercise and diet to help people lose weight around prostate cancer surgery. And we found significant benefits that you might expect in terms of quality of life, vitality, mental health. But interestingly, we were also able to find some data that correlated on the basic science side, in particular related to chemokines, which can be involved in cancer progression. So again, more hypothesis generating, but some interesting data to suggest that it does actually have an effect on some of the immunologic system and some of the factors that are involved with cancer progression.
So I want to come back to those chemokines in a moment, but first, how long did it take you to come up with this Warrior, that turn of phrase? That's pretty cool. Did you sit in a dark room for a while and just contemplate different ways to spell Warrior? What did you do with that?
Well, I have to give credit to Dr. Jill Hamilton-Reeves and her team, and actually they have lots of acronyms for it. Their lab is called EDGE, which stands for Exercise Diet Related Interventions, and they came up with the term. I don't know how long it took them to come up with that. It might have been at a bar, who knows. But,
all right, so now you're looking at these chemokines and chemokine receptors like CXCL12, CXCR4, CXCR7. It sounds like a Mazda. What are those?
So these chemokines have been recognized for a while as having importance in various stages of cancer, whether that's cancer cell migration, whether that's cancer cell progression or metastasis. They all play a role in that progression of cancer. So theoretically, by reducing the levels of these chemokines, you would reduce the risk of invasion of cancers. You would reduce the risk that they would spread to other locations.
That it is pretty remarkable. Talk to us a little bit about what a chemokine is. What do they do?
Yeah, so chemokines are essentially proteins in our system that are related to the immune system. And these chemokines, again, can be affected by a variety of factors. Many of those factors seem to be related to obesity and things like insulin, insulin growth factor, adipose tissue, or what's called as adipectin, all can relate to chemokines and influence their levels. So that's where we think obesity and the intersection of many of these inflammatory markers might have a role.
So, you've also done a lot of research on your own. You've tested 5 patients who are going through weight management How do these chemokines change?
Yeah, so again, again, hypothesis generating and small data, but you can see that the chemokines decreased in patients who were able to lose weight. And we did have controls, and we did not see that same decline in controls. So, of course, the controls were people who were not placed on exercise and diet programs and did not actually lose weight with the program, versus those who did undergo the program. All of those patients lost weight and, again, were involved in exercise and saw these declines in the chemokines.
So that's the decline from beginning to end. There's someone up there on that far left, man, they really dropped down, huh?
They are. So obviously it varies a little bit. Interesting, some of the data suggests that there might be racial differences in that. And in particular, there might be an opportunity for us in African Americans to really have a greater impact. So again, a theory that we're sort of exploring and trying to get more data on, but really, I think, fascinating data.
You know, this is pretty cool stuff. And I know you've got to, speaking of exercise, run back to the operating room because you have a patient, I think, who may be waiting for you pretty closely.
Absolutely.
All right. Thank you very much, Dr. Holzberlein. Thanks for being on the program. Thanks for letting me mess with you a little bit. If you've been on this program much, you know I love to mess with people. And as we say goodbye to Jeff Holzberlein, I just want to make note that if you get to watch Star Trek Discovery, you'll see them exercising on the program regularly, sending a great message to the Star Trek universe. That's why we say, live long and prosper. So we're also interested in your questions. Remember to answer. We're going to try and answer them. So send them to using the links on your screen from YouTube, Facebook, the social media program formerly known as Twitter, now called X, where I think Travis Kelce's active these days, or email the Medical News or email us at the Medical News Network. All right. Dr. Hawkeye.
Yeah.
Man, I warned you. It's test time today, sir.
Yeah.
So we're going to have some fun with that for just a minute. But first of all, let's check in. Number of COVID cases kind of went up just a little bit this week, but barely.
Yeah, you know, that rate of increase of the number of hospitalized patients is pretty low, that velocity of change. So we went from 14, 16, 19, and I think 20 this week. So very slow. So that is overall a good thing. We know the virus is still circulating in the community, but if we can keep the hospitalized patients as low as we can, that is going to be a good thing. And I would say, talking about exercising, if you would like to see the antithesis of exercising, if anybody has ever watched WALL-E, they'll see what happens in the future. So if you get a chance, go watch WALL-E, and that will be the antithesis of people exercising.
Now, you're a pretty big exercise freak as well.
I try when I have time.
Yeah, it is. And I love to exercise. I've had a torn hamstring, so I've been on the disabled list for a little while, but I just got released to go back to the gym today. I'm pretty excited about that, and I'll be back at it very, very shortly. Yes. Okay, so here's your test question. What is the dominant form of COVID right now? What number is it? Well, what's the variant?
Oh, I think it's basically 2. There's an EG.1.15 or BA.2.86.
Yeah, that EG5 is called Eris. Do you know why they called it Eris? This is your trick question. This is your key question. Why did we call it Eris?
Because of Taylor Swift.
No, that's a good idea. That would be a good answer.
Everything's linked to Taylor Swift, right?
Right now, I think it is right now.
It's like 2 degrees of separation from Taylor Swift
even the Chiefs' win was caused by Taylor Swift, not by Patrick and Travis. No, actually, it was named after the Greek goddess of strife and discord, Eris. I think there's Hades, that's kind of bad news, right? And Zeus is pretty good news, but Orpheus, bad stuff happens. Euripides, bad stuff happens. But Eris, strife and discord. I think somebody had fun naming that around COVID.
This is the Eris pandemic then. How about that?
It is, strife and discord. Okay, you saw a couple new studies looking into the biology behind long COVID. One was published in the journal Nature looking at the patient's blood.
Yeah.
And another was published in The Lancet looking at MRIs. Talk to us about those.
You know, we are still trying to, number one, define long COVID. What is it? Because a lot of it is so subjective in people's symptoms. And we know long symptoms can occur after any illness, especially viral illnesses, or as you have said many times, especially with more severe illness. So we are still really trying to define exactly what long COVID is. One of these, or both of these studies may help in terms of looking at people's blood or changes in their body one way, and the other study is looking at really radiology and physical changes in people's body. And we have seen some of these kinds of stories before. These two newly published studies in Nature and Lancet show, number one, yes, even after a median of a year after your infection, if you have long symptoms, they looked at changes in the blood, and they could see changes in the types and distribution of the immune cells, such as B cells and T cells. They also saw differences in the amount of chemokines or interleukins, which are chemicals secreted by our cells. They saw differences also in cortisol levels with people with long COVID as well. So they do caution that just giving cortisol, though, is not the answer to this, but we are getting one step closer to determining changes in our body in that level. The other study published in Lancet looked at people, again, with a median of at least a year out from their initial COVID infection, and they saw structural changes in organs such as the brain, the lungs, and the kidneys. They didn't really see a lot of changes in the heart and the liver compared to those people that did not have COVID, SARS-CoV-2 infection or COVID, but they actually saw physical changes in those other people with those long symptoms. So we are getting closer, number one, to defining it, exactly what is long COVID, and then hopefully moving closer to finding then remedies for any specific aspect, whether that is brain fog or shortness of breath or just fatigue and muscle aches, things of that nature.
You know, you and I have both seen a lot of long COVID patients, and I just have to say, I think that this is especially validating. Because there's been people who said, oh, they just don't want to go back to work. It's kind of like what you used to hear about chronic fatigue syndrome. Oh, that's not real. You're just depressed. Oh, you know. And clearly, chronic fatigue syndrome is real. Clearly, long COVID is real. I think it is both validating and hopeful that science has begun to find some of the changes associated in those who have long COVID, because that gives us the ability to begin to develop therapy.
Yeah, and I think that's exactly right. That coupled with the fact that we know after time, many people will get their long COVID symptoms resolved, but certainly in the acute, subacute phase, it is extremely good because it does affect people, it does affect their quality of life on a daily basis. So vitally important. Also, I think what we have been seeing is, as we have moved through the pandemic now with people with vaccination, of course, boosting, infection and reinfection, I think we anecdotally have seen less new cases of long COVID as well. So that is overall a good thing also.
You know, I'm with you about that, and hopefully the data will continue to bear that out, or if they do have long COVID, perhaps not as severe. But I think for some patients, especially if you get a double whammy, let's say you've had influenza or something else and then you get COVID, I think that's a little tougher recovery. And I think the long symptoms can last a little longer. As you step back and look at it, what is your sense about the directionality? What would be some potential therapies? And I asked that, I mean, and we probably both got the same email in our inbox yesterday. Some guy was out there trying to say, hey, acyclovir is going to solve it, and he was going to publish something in the Journal of Infectious Diseases. You're sitting thinking, I think we've tried acyclovir already. What are you talking about?
Yeah, I mean, some of these reports have gone back to 2021. Commentaries, but also case studies looking at people who have resolution or improvement in some of their symptoms for these older drugs that now are being repurposed for, not for COVID infection, not for SARS-CoV-2 acute infection, but maybe for long COVID. The mechanism isn't exactly clear, but again, even going back to 2021, there have been published case studies. There was an earlier published case study this year, case series in 2023, looking at that and having resolution of symptoms. It is very hard to say. A lot of these people now are coming up with symptoms. They have symptoms of the brain fog, the neurologic symptoms. But even one of these studies that we looked at today do support the hypothesis that there is a reactivation of latent viruses in our body, particularly herpes viruses, which most 90+% of people, or almost 100% of people, have contact and have these latent viruses in their body. And so is it really acting on the SARS-CoV-2 viruses, or is it helping to reduce the reactivation of these known viruses that we carry in our bodies from very early ages? So again, it's not new. There has been commentary. There have been studies going back to at least 2021 looking at this very common type of antiviral drug, acyclovir or valacyclovir. There's another company that's looking at a combination of valacyclovir plus celecoxib, which is an NSAID that is prescription only. It's kind of like a souped up ibuprofen, if you will. But looking at that to help cure symptoms. Now, what is going to be the ultimate effect, we don't know. Certainly randomized controlled trials rather than case studies should be done. But this is one thing that we can look into, and hopefully the NIH is looking into as part of studies to, just as you said, treat long COVID and get people some resolution or some improvement in their quality of daily life going through this. But it is interesting. Again, we are still looking to the full diagnosis. And then how do we treat it moving forward?
Yeah, and one of the things I would encourage our viewers to not do is go jump on the internet and try and find all these people who are now purporting that they have long COVID cures. And that's kind of like some of those other health food kicks and stuff that people get onto. Remember, A, there's no science around that. We just described the science. Thank you, Doc Hawk. Yeah. B, that these are kind of made up things and they're made up by people trying to make a profit. C, that the side effects of these can be very significant. And I mean, I know you've treated, I know I've treated patients who have taken these special remedies, internet remedies, and all of a sudden what happens is they get sicker instead of better. And then D, it can cloud and help us not know how you're doing because we don't know if you're having a problem with the drug or you're having a problem with long COVID. There are emerging therapies, and I think we would stick to that. Remember, we've said all along on this program, the combination of faith, hope, and science is powerful. I think the scientific engines are turned on around long COVID. I believe we'll continue to see major progress. And I think this concept that, man, you have COVID, COVID may actually reactivate other viruses that we hold latent. You know, like when if you had chickenpox as a kid, shingles is with you forever. That zoster didn't go away. It sits sitting in your nerve roots, waiting for a pop for something to cause it to come out, like severe stress. I just saw a patient yesterday that had a lung transplant patient, and she had her first outbreak of shingles. And you sit back and you're like, wow, a lot of stress had happened, and now she has this. So we got to be careful. We'll sort this out, but trust the science, Hawk.
Yeah. No, I think that's great that you mentioned that specifically. Even in this article that we looked at today, they do mention, possible reactivation of VZV, which is that virus that causes chickenpox and then shingles, but also other viruses like EBV. So I think it is important to understand that. We certainly want to take all of these things into account. I think we still need to do more research and look at that. And again, most importantly is that shared clinical decision making, talking with your primary care physician or that physician that is dealing with that long COVID as well.
All right, so I bet there's some questions out there today, and we know that in Studio B is Alexis Del Cid. Alexis, how you doing this morning?
Good morning. I'm doing well, feeling good. I started exercising at a gym, so I'm following your advice.
Excellent
plan. So I have more energy. I have a lot of questions coming in. The first one is for Melissa Bunzinski, who's watching us on YouTube. She would like a specific answer to when the COVID vaccine will be available for kids 12 and under in the Hayes area.
Oh, wow. That's a good question. I can't tell you exactly the answer to that. There have been some problems in the rollout of this vaccine, but you have to remember, A, just as every other time we've rolled out vaccine, it takes a while to get production ramped up and get it everywhere. B, there's been some changes around insurance, remember, because before COVID vaccinations were always free, and now sometimes you have to go have insurance to do it. And so C, there's been a distribution thing. There's also been a little economic change this time, Hawk.
Yeah, I think that's the biggest issue or comment. Certainly, you mentioned production. We know that early on in the spring they said what spike variant they were using to make it. It unfortunately was delayed in production for some reason. We still don't understand why. So we know production was delayed on the very front end, and then certainly distribution. Now we do know that some of the commercial pharmacies get it. Hopefully in Hayes, if you do have commercial pharmacies there, such as CVS, Walgreens, and what other local pharmacies you may have, check with those. But certainly we know distribution is rolling out. It just may not be everywhere. I don't have a good idea exactly for when it might be there in Hayes.
Two thoughts. One, check with the public health department in Ellis County, which is where Hayes, I believe, is. And B, you could call Hayes Med and talk to your, I'm assuming that someone has a primary care physician around Hayes, and most of those folks are connected with Hayes Med, and I think Heather Williams is the CMO there, so I think there's some good sources of information.
Yeah.
You can probably tell you more specific about what's going to happen. I think that public health department would be a great choice.
Got a question from Sharon Chapman Whitlaw. She wants to know, if you had COVID in the middle of May, is it time to get the booster? I had the flu shot a week ago.
Okay, Hawkeye, middle of May, kind of getting close.
I think so. You know, we have been recommending really 3 months from your acute infection, so I think it'd certainly be reasonable at this time to go ahead and get it. Yeah.
So here's a question. If you had the bivalent booster 3 months ago, would you get the monovalent one, or would you go ahead and wait for a 6-month interval?
Yeah, I think that the recommendations, I have to go back and look, is that you are available, you are okay to get a new updated vaccine if your last dose of vaccine, COVID vaccine, was 2 months or more. It's either 2 months or more or 4 months or more. I had to look up the specific, but I believe it's if you received your last dose, no matter what kind of bivalent or monovalent previous to that. But if it was 2 months prior, you are okay to get the vaccine.
All right. Alexis Del Cid.
Ruth Ellen has a question about shingles. She wants to know if you could please repeat the shingles connection, because she has 2 close family members that have just had shingles, one in their 40s, one in their 70s, and the 70-year-old had the shingles vaccine.
I think a couple of things are probably important to remember. I'm going to start this out. I'll kick it over to Doc Hawk. You know, remember that shingles is caused by the herpes zoster virus. That's chickenpox. You usually have it when you're young, but it doesn't really clear out of your body. It tends to hibernate inside nerves, and often the nerves that are close to the skin. Then when other diseases come along, or you may just have severe stress or some other challenge to your body's health, then those viruses can reactivate, so to speak, and it pops out with those shingles, those kind of lesions on your skin that look like little clear, we call them vesicles, and they can be incredibly painful and tender to touch. They tend to run along dermatomes, which means like a band of your skin, and it can go from your back all the way around to your chest, and sometimes it can be more disseminated, which means it's in several dermatomes and get up around your eyes. It can even start to affect vital organs. Those are usually in patients who are very immunosuppressed. So we do care a lot about shingles. We want to make sure you get care for it. And Doc Hawk, long COVID sounds like it's part.
Yeah, so again, shingles we know can be brought on by COVID infection in general. Just like you said, Steve, really any stress. And I think there are even case reports even after getting the mRNA vaccine of shingles. What was the question exactly, Alexis, though?
She wanted a clarification on what you had said at the top of the program about shingles. And then she was curious because one of the people in her family that she knows that got shingles was a 70-year-old who she says had been vaccinated.
Okay.
Yeah. The 70-year-old is going to be susceptible to shingles for a lot of reasons. And it could be connected to the vaccine. It could be connected to, again, shingles happens to people if you've had chickenpox, if you've ever been in contact with herpes zoster.
Yeah, and I would say that, you know, certainly the shingles vaccine will significantly reduce your chance of getting it. It's unclear maybe what vaccine she got. There is a newer one out, Shingrix, that's been available for several years, but there was an older one as well, so it's unclear which one she got. If she got the older one, it's certainly understandable if she maybe got a recent episode of shingles. And it is recommended after an outbreak of shingles to get the vaccine still, because it will still reduce your risk of getting shingles again. But other than that, don't have any other comments. But
yeah, I would just say to the family members, if you're at risk, make sure you've gotten the shingles vaccine. It's available to those over 55, right?
Shingrix, and it's 50 and over, yes.
Okay. And secondly, if you've just had shingles, you may talk to your primary care doctor, see if you would qualify to get Shingrix again. And third, make sure you talk to your primary care doctor. They probably have some more answers for you about what your individual risk profile looks like relative to shingles.
I have a question. This is for me, a viewer named me. Dr. Hawkinson, you remember I had shingles last year because I was texting you pictures and crying over it. You were so nice. Benefits of having your cell phone number. Do I need to get vaccinated if I've already gotten it? I'm not 50 yet, so I can't get vaccinated yet.
Yeah, I would, at 50, you know, as your 50th birthday present, I would certainly go get your dose of vaccine. It's a 2-dose series. You get the first one, and then 2 to 6 months later, you'll get the second one. But once you turn 50, yes, absolutely recommend. So you can reduce your risk greatly of getting it again, especially a worse case or something like a case on your face, which we do see commonly as well, Steve.
Yep. And viewer named me, Alexis, remember that you don't have to do it on your birthday. You give yourself the day off, have some party, and go the next day if you want. It is 2 shots, 3 months apart, and it can make you feel a little sick, just like influenza vaccine can.
I like that idea better. That I do not want that to be my present on my 50th birthday.
Yeah, 50th
well, I'm an ID nerd, so that was
unless you're coming with me and we're going and have a beer afterwards, Dr. Hawkinson.
We're there.
Or Dr. I want both of you with me.
You're talking to Hawkeye. You invited Hawkeye for the beer, not me. I got it. Don't worry about that.
No. I want you both. That would be a fun night. All right, we'll get to that later. Gene has a question. Gene wants to know, this is specific about Michigan. He wants to know if there is a new variant in Michigan. As you know, we have viewers all over the country.
Yeah, we've heard this before.
Yeah, I would say there's likelihood of some new variant of some degree everywhere. Unfortunately, our surveillance systems now for looking at variants and genetic testing and the amount of testing that we are doing for that is significantly reduced to where it was at the height of the pandemic. So that is not a surprise, but will that variant take hold? Will it sweep the country? That's hard to say. We've known also since the pandemic, we've identified numerous variants which thought was going to take hold and become very predominant, which never did. So there certainly could be, but I think there continues to be just a lack of genetic surveillance for one reason or another since the height of the pandemic. So I think we just have to wait and see if that does start to predominate. My hypothesis is, though, that any new variant right now that we continue to see will not be incredibly different than all the variants that we have already seen. I think it would take significant fundamental changes in the virus itself to produce things like increased severity or different disease, but we need to always be vigilant and watch for those changes as well.
One more question from Denise. Denise wants to know some clarification on the timing and if it's safe to get the COVID vaccine, RSV, and her flu shot all at once at that one doctor's visit.
You can co-administer. They do recommend different sites, but you are able to co-administer those vaccines together with other vaccines as well. Really, the biggest one you want to avoid co-administration is Jynneos, which is the smallpox or Mpox vaccine. You really don't want to co-administer that with other vaccines, especially COVID. And then possibly Shingrix, but really most all of the other vaccines you can co-administer.
We had Dr. Paulin one time say he wasn't sure about doing RSV and influenza together, but others have said it's okay, so I'm not sure where to stand on that one.
Yeah, and his statement came because of, again, a couple cases during those studies of people that had gotten same day or close to influenza and RSV vaccine together. There were 2 cases of Guillain-Barré, but the official recommendation from ACIP is that those vaccines can be co-administered. So now, certainly we will continue moving forward looking for data signals in the RSV vaccine, just as we do for the COVID vaccine, for anything that may be an issue. That is the nice thing that we continue to do, is that active surveillance for vaccine safety. And what these vaccines have shown is that they continue to be very safe.
They are incredibly safe. And once available, I'm sure we'll be getting our COVID vaccine right here on this program in the very near future. We'll have to pick the date, won't we?
Yeah.
All right, this has been another great discussion here. I'm always grateful for our guests, Dr. Ojo and Tammy Peterman, who were here earlier talking about all of us, Dr. Holzberlein talking about exercise and cancer, and of course, Doc Hawk. Final thoughts, sir?
I think these were great questions, continued. I think it just continues to say we are continuing to look for definitions, the definition of long COVID. It is difficult. We are making headway based on objective findings such as labs and imaging, but we know it is affecting people's daily lives continuously. It continues to affect daily lives. Research still needs to be done in ways to treat it and reduce those symptoms. Those are ongoing as well. And again, these vaccines continue to be very effective and very safe at reducing the severity of disease, really for whatever disease process we are talking about. So.
You know, we've talked many times in this program about the impact of faith, hope, and science. Here's a story. When is it safe to laugh? So, you know, I treat patients, we've talked about it before, with cystic fibrosis. And in the last few years, therapies were developed directly affecting the protein that is important to having CF patients survive. Historically, they had a hard time with their sweat or their sodium concentrations, and as a result, they had really thick mucus. And so when they went out in public and they started to laugh, they'd start to cough. And so it became this embarrassing thing. So by and large, CF patients tended to stay home or have very small circles of friends. I sat and talked with one of my CF patients recently. I said, what's the best thing about being on this new drug? It's called Trikafta. And she told me it is being able to laugh in public, to be able to go to the movie and laugh again, to be able to sit down and go out to dinner and laugh at dinner. You know, we think about the small things in life, but sometimes these small things like laughter are actually a sign of really, really big things. That's why faith, hope, and science are so important, so that we can all laugh together. And we can wait for the big things, because these small things, you know what? They add up. We'll see you next week.
Heart disease is the #1 cause of death in the United States. I'm Alexis Del Cid. On the next All Things Heart, it's almost World Heart Day. So we'll bring you remarkable stories from patients who are benefiting from the latest therapies and technology, and how you can lower your risk of heart problems with some simple things you can start doing immediately.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.